Welcome to the U.S. Healthcare System Lecture Series by Monika Wahi, based on Essentials of the U.S. Healthcare System by Shi and Singh. These first two lectures are on Chapter 1, on major characteristics of the U.S. healthcare system. They are split into two different lectures. The first lecture covers the different subsystems and how they interrelate in the U.S. healthcare system. The second lecture covers how the U.S. healthcare system is different from other healthcare systems of similar countries. In the first lecture, which we will do now, we will look at all the different subsystems in the U.S. healthcare system and how they fit together or how they don't. As a matter of fact, if you can find a way to make them fit together, that would be wonderful. Chapter 1. Major characteristics of the U.S. healthcare system. First half. Learning objectives. At the end of this lecture, students should be able to name 3 subsystems of the U.S. healthcare delivery system, describe at least one way healthcare delivery is financed, and define what an integrated delivery system is. Introduction. Healthcare delivery and health services delivery have slightly different meanings, but both terms refer to major components of the system. They refer to processes that enable people to get health care and the provision of healthcare services. Did you know that the primary objectives of any healthcare delivery system are to enable all citizens to receive healthcare services whenever needed, or universal access, and to deliver services that are cost-effective and meet certain pre-established standards of quality? If you grew up in the United States, these two objectives may come as a complete surprise to you. The U.S. is different from other systems in other developed countries. Most developed countries have national health insurance programs, and these are referred to as universal access. These take care of one of those two primary objectives I just stated. In these other countries, that system is run by the government and provides routine and basic health care. By contrast, the U.S. system does not currently have a national health insurance program that provides universal access. All Americans are not entitled to routine and basic health care services. However, we are entitled to a public defender. What if you grew up in the United States and went on vacation to another country and got hurt? This happened to somebody. It happened to a young man who went to the Bahamas. He put his hand through a window. He got all cut up, and because I was standing at the bus stop, I helped him. As we were in the bus, which was actually a van, driven by a bus driver I had met who had given me his phone number, while we were talking, the young man looked at me with his arm bleeding and said, "How am I going to pay for this?" And I reminded him that the Bahamas were not part of the United States, and so therefore it was likely he would be able to afford his care. He was happy to learn, when he arrived at the emergency room, that everybody got charged the same amount, $45. The textbook on which these lectures are based was new as of July 2012, and so the Affordable Care Act is mentioned. However, when these lectures were recorded in May of 2013, a lot of updates had occurred. The textbook approaches dealing with talking about the U.S. healthcare system by using a systems framework. I will discuss this at the end of the next lecture over the second half of Chapter 1. Although we say it is a healthcare system, it's not really a system in that the components are loosely or sometimes not really connected. And there's a lot of components. What those components actually are and how they are loosely or more tightly connected, and also which ones are connected to which ones, are the subject of this course. Subsystems in the U.S. healthcare system. There are many, many, many system components. There are healthcare plans. There are rehab therapists, There are dental schools. There are osteopathic schools. There's private health insurance, Medicaid and Medicare. There's too many to mention. In the large U.S. healthcare delivery system, there are many subsystems. 6 are highlighted in the textbook. These include managed care, the military, special populations, integrated delivery, long-term care delivery, and the public health system. These systems are not independent. These subsystems interact. However, it would be impossible to write the book and explain the U.S. healthcare delivery system if we didn't separate some of them out and talk about them separately. So that's what we're going to do here. The first of these subsystems we will talk about is managed care. The philosophy behind managed care is about integration, determining price, and managing utilization. Managed care is a system of healthcare delivery that seeks to achieve efficiency by integrating the basic functions of healthcare delivery. It employs mechanisms to control or manage the utilization of medical services, and it also determines the price at which the services are purchased, and therefore how much providers get paid. Remember, managed care itself is just a philosophy. It's just a way of approaching trying to deliver health care. Managed care organizations, on the other hand, are organizations that actually try to do that. Managed care is the most dominant healthcare delivery subsystem in the U.S. It's abbreviated MCO for Managed Care Organization, and these are available actually to most Americans. The primary financiers of these organizations are employers and the government. So the MCO ends up acting a lot like an insurance company. Employers and the government contract with them to offer a selected health plan to employees if it's an employer, or to Medicare and Medicaid beneficiaries if we are talking about government insurance. Financing in managed care organizations is quite complicated. This is simply because they want to set it up such that they manage utilization efficiently. They want to make sure to put all the right cost controls on utilization and on payment so everything works out so everybody gets optimal care. One approach to doing that is to use capitation. Capitation means for one set fee per member per month, in other words, for a certain amount of money per person in the MCO plan per month, the MCO promises to deliver all needed health care services, whether the enrollee has a good month and doesn't need any services, or has a bad month and needs a lot. That's one approach. Another approach is discounted fees, and there are different ways of doing this. Insurance, in the case of the MCO, they assume the risk and act as an insurance carrier. So if you have a catastrophic accident, the MCO will take care of you. Also, in terms of delivery, the MCO arranges to provide healthcare services to the enrollees, either directly or through contracts. So the MCO makes sure that everybody who is enrolled in their plans can have services. However, they implement various types of control to manage that utilization, and that also manages cost. Also, payment. When it comes to paying, the MCO acts as the payer. The MCO disperses the payments to the providers based on capitation or discounted fee arrangements. Many terms are used in MCO speak, so we need to make sure we understand them. An enrollee refers to a member of the health plan that the MCO offers. And of course, the health plan then is that contractual arrangement between the MCO and the enrollee, which involves providing access to health care. It includes a list of the services the enrollee can expect to get as part of being on the health plan. Also, there are selected providers the enrollee can go to. Often, the MCO uses primary care or general practitioners, PCPs as gatekeepers to specialty providers. You need to ask yourself, why all this control over providers and health services? Why does the MCO want to do that? Why is it in its best interests? In 2009, many Americans were on different kinds of MCO plans, which we will talk about. As you can see, the yellow bar represents the number of Americans in millions who are on an HMO plan. The red bar represents the number of people who were on the PPO plan. As you can see, those are the two most popular plans. The POS plan is not very popular, probably because that's not a very good abbreviation. The next plan, the HDHP, turned out to be not very popular, although it was a fad in the early 2000s. Let's examine how managed care integrates functions. Managed care starts by operating like an insurance. This insurance creates contracts with providers to deliver health care, and by that way, enrollees in the MCO's insurance now have access to certain providers. The insurance also pays those providers. That's wonderful. I would love it if my car insurance limited what gas stations I could go to, because it would be wonderful. They'd pay for my gas. Of course, my car insurance would probably be astronomical. Sound familiar? Let's move on. Those providers end up, in a way, financing the insurance, because every patient that comes to them has to go through being served by this contract, and so if the patient doesn't have the right insurance, they won't be served, right? And so all of the marketing of getting patients to sign up for insurances that then take the providers is done by the providers, and so they are able to finance back the insurance. The insurance sets up risk underwriting, capitation or discounts, and utilization controls. The purpose of this is to keep everybody honest, since all this money is being passed around. First, risk underwriting mitigates the situation between the financing and the insurance. In other words, the risk underwriting tries to run interference there so that risk is managed properly. The insurance does not want to take on too much risk, but it has to meet its obligations if it has taken on risk. So this financing and risk underwriting is a balancing act that the insurance does. The insurance is also very careful to use capitations or discounts as described in earlier slides. That way they don't have to pay that much, and they can make sure that the enrollees do not overuse the health care provided by the providers. One thing that's very interesting about this diagram is there are no patients in it. Where are the patients? I don't see them. In fact, do you even really understand this diagram? It might be a little bit easier to simply give you an example. Here is an example of Hennepin Health. Minneapolis, Minnesota, where I grew up, is located in Hennepin County, and Hennepin Health is a health plan administered by an MCO called Metropolitan Health Plan. This MCO has a list of selected providers to choose from and provides a list of covered care and pharmacy formulary. And I used to work there. It was one of my favorite jobs. Next, we leave managed care and move on to the military subsystem. In the military subsystems, two main groups are served: active service members and veterans. Active service members are covered by the TRICARE system. When they leave active service, they are given a choice between joining the VA system or just going into a civilian system. Those that choose the VA system then remain in it. So basically, the problems that are created during the TRICARE system, when a person may be serving active duty and may even be at war, those problems get handed off often to the VA system, where they pile up. The characteristics of the military subsystem are interesting. There are three main ones. On one hand, they combine medical care with public health, and that bodes well for prevention. There's high quality of care in the military subsystem, but there is little choice. And there's a mixture of uniformed and civilian providers. Together, this mixture provides good prevention and treatment. TRICARE is where active service members get their medical care. It is free of charge to all of them. Unlike the rest of us, they have no co-pays and no deductibles, which seems fair, doesn't it? The following are enrolled in TRICARE. You have the Army, the Navy, the Air Force, and the Coast Guard, but certain other governmental entities. TRICARE includes access to care at military treatment facilities, or MTFs, which are on location at bases, as well as treatment in regular hospitals in the community, like Newton Wellesley Hospital. TRICARE is financed by the military. The VA healthcare system is available to veterans, people who used to be in TRICARE. The VA healthcare system focuses more on hospital, mental health, and long-term care given its population. It's one of the largest and oldest health systems in the world, and it provides medical care, education, training and research, and all kinds of support for the Department of Defense medical care system. The VA system is organized into 23 VISNs. A VISN is a Veterans Integrated Service Network, spelled VISN and pronounced VISN. The VA budgets over $40 million per year and employs over 280,000 people. Therefore, if you want a job, you probably should go over there because they have $40 million. As you can see at the bottom of the slide, there's a screenshot from our local VISN in Boston. In the United States, how we address these problems of access to care in these groups of people that we care about but don't have much means is that we set up a governmental agency. So if you'll notice at the bottom of the slide, you will see that we have the Department of Health and Human Services. That's that big governmental agency in the U.S. that takes care of all this stuff. Inside them is HRSA. HRSA is the Health Resources Service Administration. That's another agency in the U.S. government that's in charge of health stuff. Underneath them is the agency that's in charge of all these special and vulnerable populations that get kicked to the curb when they do not have insurance. And that is called the Bureau of Primary Health Care. You may not have heard of it, but it's been around for over 30 years and has been providing primary and preventive health services to all these populations on the slide. Are you homeless? Are you stuck in public housing? Did you find yourself a single parent of a school-aged child? Are you suddenly uninsured? Did you lose your job in the recession? Maybe you're part of one of these groups now that is being served by the Bureau of Primary Health Care. In 2010, the BPHC supported over 1,000 community health organizations. Those community health organizations served almost 20 million people. Well, I just checked the U.S. Census on the census population clock, and there are about 315 million people in the United States right now. So in 2010, the BPHC served about 6% of them. So 6% at least of the United States did not have health insurance and went to the BPHC. Although that kind of doesn't make sense, because if you see way over on the right side of the slide, only 38% of those who were served by the BPHC were uninsured. So why is it that people who actually had insurance theoretically had access to care in 2010 but still went to the BPHC? There are only about 8,000 service sites, and when you think about the entire United States, there are probably a lot more service sites for other places. The BPHC was handling 77 million visits in 2010. That's a lot of visits. 93% of the people who came to these community health centers in 2010 were making less than 200% of the poverty level. That is very poor. Yet a lot of them had insurance and couldn't use it. That really doesn't look very good for the richest country in the world, does it? To add to the complexity, some people actually do have health insurance, but it's public health insurance. A lot of those people who went to those BPHC sites probably already had public health insurance. What is public health insurance? In the United States, that's health insurance that's supported by the government. We have two main kinds. The first kind on the left side of the slide is Medicare. Medicare is one of the largest sources of public health insurance, and it covers elders, disabled, and those with end-stage renal disease. That's a group of people that's very important, but it certainly isn't everyone. So over on the right side is Medicaid. This is the third largest source of health insurance in the U.S., and it covers 16% of the population. These people are not the elders who are covered in Medicare, but they are low-income adults, children, and elders and disabled who need additional care according to Medicare or simply do not qualify yet for Medicare. Also, Medicaid has been expanded over the years to make sure that low-income children especially are covered. And this is through the Children's Health Insurance Plan, which is part of Medicaid. It's called CHIP. And we will learn more about this in subsequent lectures. Back on the left side of the slide in Medicare, remember those governmental agencies? Remember that big one on top of the BPHC called DHHS? Well, DHHS has another agency called CMS, or the Centers of Medicare and Medicaid Services. That CMS runs Medicare and Medicaid. And Medicare, the one for the elders, disabled, and those with end-stage renal disease, covers hospital care, post-discharge, nursing care, hospice, outpatient, and prescription drugs. As you will see as you go through this book, there are many differences and similarities between Medicare and Medicaid. One of the important similarities to highlight here is that both of them are public health insurance. Both of them are ways that the U.S. tries to cover special and vulnerable populations with insurance so that they can have access. But as you can see by our last slide, it doesn't always work. You may be an American who has used or needs to use safety net providers. If you are not, you may not understand how hard it is to actually do that. First of all, these safety net providers are not secure. Even though there are those community health centers, different programs start and stop depending upon availability. Provider types may not be available when you need them, and other providers may be available that you don't need. For example, I have a friend who only responds to acupuncture. She can go to community acupuncture when those programs are available. However, when they go away, she is stuck taking pain drugs, which kill her. Some individuals forego care and seek hospital emergency services if they are nearby, simply because the provider type and availability varied such that they didn't exist anymore and there was no safety net. So there was a hole, and falling through that hole, they were caught in the emergency room. At the emergency room, the providers were pressured to see the number rising of uninsured. There are laws that make it so if you go to the emergency room in the United States, you have to be seen. But there are other pressures in the United States recently with the recession and a lot of people being unemployed and therefore losing their health insurance and not being able to see the doctor. Providers in the community feel bad for these people. They care about the community. So they have worked very hard to put together community funds to try to serve the community. However, at some level, these providers are businesses. They simply can't give away free care. In Medicaid, the primary financial source for the safety net does not allow much cost shifting. Imagine you budget $100 a month to repair your car. However, your car doesn't need to be repaired very often. So after the first few months of the year, you find that you have an emergency. Your child is ill. You need to use that $300 or $400 that you had saved for car repair for your child's illness. Cost shifting in a family is not hard. You simply reallocate that cost. However, in Medicaid, if a certain amount has been budgeted for preventive care, such as mammograms, and a certain amount has been budgeted for curative care, such as chemotherapy, sometimes it is hard to move those things back and forth between the buckets. What are the implications of this? We can see a real-life illustration of the trouble with safety net providers when we look at Komen for the Cure. Komen for the Cure is an important organization that is known internationally. It has a high reputation for fundraising for breast cancer prevention, treatment, and research. Many women have been helped because they have gotten mammograms or treatment that was funded through work that was done by Komen for the Cure. However, in February 2012, there was a public relations snafu at Komen for the Cure. First, they said that they were not going to forward funds to Planned Parenthood, which was one of the places that delivered services. Then they changed their mind and said that they would. However, by then they had turned off a lot of their donors. For example, in the Seattle area with the Puget Sound Komen for the Cure, the Komen there reported losing $750,000 in donations that would have gone to mammograms for disadvantaged women. So if you were a woman in Puget Sound and you were getting your yearly mammograms supported through Komen, then last year you probably didn't get a mammogram. This is what happens in the richest country in the world. We have to rely on outside non-governmental organizations to get all our women mammograms to prevent breast cancer. That's where our ethics lie. Now we will move on to the next U.S. healthcare subsystem, integrated delivery system. In the integrated delivery systems concept, you will see the objective is to have one healthcare organization deliver a range of services. This new IDS approach is the hallmark of the U.S. healthcare industry. Basically, rather than having the government control all of our healthcare in one big organization run by the government, private organizations and public organizations are coming together into these large integrated delivery systems. In reality, this is a network of organizations that provide or arrange to provide a coordinated continuum of services to a defined population. So in other words, integrated delivery systems is an example of our little subsystems trying to come together around particular populations. I gave some examples of the military populations, and we just heard some examples of special populations. So these defined populations are targeted by the integrated delivery system, and then the subsystems are set up around it to try to make sure those defined populations get care. And so that integrated delivery system that's set up around that defined population is held clinically and fiscally accountable for the outcomes for their health statuses. Isn't that a lot easier than just having the government take care of its entire population? So the IDS involves various forms of ownership and links among hospitals, physicians, and insurers. Isn't it more important to have 1 million people at the table than just have the government run it? Because actually, if you don't have all these people involved, they won't have jobs, and there's no place for all that extra money to go. I will give you an example of an IDS with which I'm familiar. Allina Health Systems in Minnesota. In the 1990s, Allina Health Systems started to acquire a lot of different healthcare entities in Minnesota. Maybe that sounds greedy, but to be honest, a lot of them were struggling. Minnesota's a big place, and there were a lot of rural clinics that really needed the support. Allina went around and bought up a lot of these. And so therefore now there are many facilities throughout urban and rural Minnesota that are part of Allina Health Systems. Allina acquired Abbott Northwestern Hospital downtown Minneapolis and also has hospitals in rural areas. So these network of hospitals and clinics offer all type of care, including mental health, which can be very hard to get to in the rural area. Think about the advantages of being a large organization that offer all different types of health care. Although I may sound cynical about a lot of these IDSs, one good thing that Allina brought to Minnesota was a way of making sure people in the rural area did have access to all the different kinds of things that you can get at the various hospitals, such as different diagnostic techniques, laboratory techniques, surgical techniques. All of that became available. However, you still have to drive. Long-term care consists of medical and non-medical care that is provided to individuals who are chronically ill or who have a disability. Normally, when we think of long-term care, it calls to mind older people in skilled nursing facilities. However, there are plenty of Americans who have to live in long-term care as part of their regular adult lives, such as certain autistic adults who cannot live on their own, or particular older adults who get Alzheimer's and need to live in special Alzheimer's treatment units. These are just two examples, but there are other examples of long-term care that adults use that are not skilled nursing facilities. This is why by 2020, more than 12 million Americans are projected to require one of these long-term care settings. Given the previous subsystem I talked about, IDS, I want you to think about this question. How are LTC and IDS connected? Right. They're not connected. Anybody who has had a loved one in a skilled nursing facility who is starting to fail in their health knows how disconnected long-term care is from the integrated delivery system. In that situation, often the elder gets pinballed back and forth between being admitted to a hospital and being sent back to the skilled nursing facility. Everyone gets angry in this situation. The skilled nursing facility gets angry that the patient is failing and that they do not have the ability the way the hospital does to take care of those advanced medical needs. The hospital gets angry because when they receive the patient, they have a different opinion. They feel like the patient could have been managed at the skilled nursing facility. The family gets angry that the patient is being transferred back and forth because it's hard on the patient. Often they get confused or hurt, or some sort of care problem occurs in that transferring back and forth. The patient tends to get angry because, well, wouldn't you? Insurances get angry because they don't like to pay for this. And if the taxpayer is paying for Medicare or Medicaid for this person who keeps getting transferred back and forth, that person gets angry too. So this is a good way of making everyone angry, and that is keeping the LTC disconnected from the IDS. Finally, we move on to my favorite subsystem, public health. There are many functions of public health. You will see on this slide and the next what public health is supposed to do. In fact, I would say in the U.S., public health does a pretty good job of doing all these things on a dime. That's right, a dime. You will see in later lectures how much we fund public health in the United States, which is almost nothing. You will see that the military really funds it and that other countries with national health care fund it because they have figured out that it is cost effective. It is cheaper to prevent cancer than to treat it. It is cheaper to prevent infectious disease than treat it. It is cheaper to prevent mental health problems than to treat them. That is a secret known by other countries, but we don't seem to understand it here. So we underfund our public health and try to make it do all these things on the next two slides, and then when it doesn't, we give all the money to the healthcare system to try and cure what public health didn't prevent. Here's what public health is supposed to be doing right now, is trying to do with almost no budget, and would love to do more of if you would just give them some more money. The first one is monitoring the health status to identify and solve community health problems. One good way to avoid having a reputation of having a lot of foodborne illness is to simply not study it. So therefore, places that appear to have very little foodborne illness generally don't have departments of public health who are studying it. If you monitor the health status of your community, you will find bad news. And so one way we avoid doing that is by just not funding those efforts. Public health also diagnoses and investigates health problems and hazards. So for example, I heard a lecture from somebody who investigated whether factory farming in North Carolina was contributing to asthma in the population. That person was attacked by industry. A lot of my colleagues are attacked by industry. All you have to do is read about big tobacco and what they did to public health and epidemiologists, and you will see that it is kind of anti-industry to do this, to diagnose and investigate problems and hazards in the United States. So we try to avoid that. Public health also informs and educates people about health problems and hazards. Of course, nobody's very angry about health problems and hazards, which means we haven't been doing our job. If you've been listening, you should be angry. However, not everybody is listening because not everybody can get the message. We also are supposed to be mobilizing our community to solve health problems. However, it's pretty hard to mobilize your community if you don't have any money. And it's pretty hard to do so if you have a lot of confusion in your public health field about what you're supposed to be doing. Because remember, that's only one thing on this slide. In public health, we try to develop policies to support individual and community health efforts. However, there's only so many policies we can develop, and there's only so much we can do with those policies if you don't give us any money. There are more functions of public health, and they can barely get done. Did you know that that the public health department in your state makes sure that the providers practicing healthcare in your state are licensed to do so? Public health enforces these laws and regulations in addition to doing everything on the last slide. Public health is focused on providing people access to necessary care. So public health tries to help the BPHC and other efforts to covering people who are uninsured who otherwise have barriers to access. Public health has to train a lot of people. Public health trained me. It's trying to make a competent and professional health workforce. Of course, if you don't give it much money and you don't really care about it, it's not going to do a good job of that. So I can't say that all my colleagues are as good as I am. Finally, public health has to look at the effectiveness of things and the research behind things. We have to look at programs we put in place to see if they actually work, and we have to do research to try and find solutions. With all the other stuff we have to do, and we have no money, we spend all this time competing for grants from the government to try and do these things. We don't get paid for competing for grants, and half the time we don't get them. So therefore, if you don't want to give public health a lot of money, the good news is you won't find out a lot of bad news, but the bad news is you'll still have the bad news, you just won't know about it. Here are two examples of public health in the United States. The first is an example of our flu vaccine system, which is run by the Center for Disease Control, or CDC. Throughout the year, the CDC monitors the different flu strains to figure out which ones are becoming popular. It does research on these strains and also does research on who in the U.S. will need the flu vaccine once it's made. It also arranges for the vaccine to be made and for people to have access to the vaccine, and develops informational campaigns and educational campaigns for providers and patients. This is how we all manage to have access to this vaccine every year. A different effort, which is totally different, has to do with the Behavioral Risk Factor Surveillance Survey. This is a national survey in the U.S. that is designed to try and figure out the rate of risk factors in the U.S. that are behavioral risk factors, such as smoking. If smoking levels rise in the U.S., how would we know without the survey? So this monitors these risk factors and looks at diagnoses and investigates health problems, such as asking everybody if they have obese children to figure out if that's going up. Datasets from the BRFSS are available online from the government, and so if you're a researcher, you can use them to do research. A lot of researchers use them and they publish, and this informs and educates the public health effort in the United States about what to do about these things. This is the conclusion over the first half of Chapter 1. As you learned through this lecture, there is not one big system. There are several subsystems, and they are integrated in kind of a loose fashion, and sometimes they're not even integrated. However, managed care organizations are jumping in to try and help us integrate. They are now the dominant way in which Americans access healthcare providers. And if you aren't lucky enough to be part of one of those, safety net provisions are put in place for those who do not have access to health care by way of insurance through a managed care organization. Now we are at the end of this lecture, and you should be able to name 3 subsystems of the U.S. healthcare delivery system, describe at least one way healthcare delivery is financed in the U.S., and define what an integrated delivery system is. I hope you enjoyed the first lecture over the first half of Chapter 1. I hope you now understand the different subsystems in the U.S. healthcare system and how they fit together, or they don't fit together, into an integrated or not so integrated delivery system. In our next lecture, over the last half of Chapter 1, we will see how different we are from other countries who are also trying to make these things fit together, but they fit a little better.